Thank you everyone for joining. I am Cathy Dumbrava from MD Anderson Cancer Center in Houston, Texas. You can see that our project had three parts. One was the pre-intervention, which took up to 2 years to look at the retrospective data. There was the intervention, which was about 3 months, which resulted in a second data pull from the electronic medical records. And after that, there was a post-intervention where we are right now, and that it's up to 18 months to really look at the results of the interventions. And so just to review very quickly. So first, we try to identify what are the gaps, and we try to do this at each site. One, for some of the gaps that were identified, or that there are delays in molecular testing, in scheduling patients. Also, there is no standardization. And I know that Dr. Kuo will discuss some of the challenges of integrating these results with the electronic medical records. And also, how do we document these, and how do we create some databases that we can after that use. The second step, which was the intervention, were some online sessions that were interactive. And I know that that some of you joined during these sessions, and there were internal meetings and discussions with the leads of the PIQI projects at each site. And after that, we also had a test and evaluations. And also for these online sessions, that they are it helped to create some interviews with all the participants and understand some of the challenges of these processes and how we can really improve this in the future. I know that it's very hard to attend webinars, and we have so many things and so much education. So how do we do this in a very time efficient manner? So it really shows the impact of a PIQI project, and how can this be achieved within an academic center. And so the two sites in between Banner and Baptist, they are different settings that might have different challenges. And I know that Dr. Kuo, Dr. Wu will discuss about these. And it is very important to create an action plan that is unique for the institution, and to make sure that we align the overall goals and objectives of the program with the needs for the institution and the patients. And so overall, both sides we were identified as objectives and they were able to demonstrate that we are able to increase molecular testing for patients, that we are able to improve the documentation. And I believe that for both of the sites, we were able to show that there is an increased advocacy for molecular testing among different multidisciplinary teams.
So let me tell you a little bit about my hospital system. I'm currently at Baptist Health System in Jacksonville. It's the largest healthcare provider in the northeast of Florida, in the Jacksonville area. It composes of 6 hospitals systems, 3 freestanding ERs. It employs over 2,000 physicians as part of the hospital system. We are a part of the hospital system, the oncology part of the division, called Baptist MD Anderson Cancer Center, as a partner site for MD Anderson in Houston. So one of the things that got us interested in this particular project is that we were looking at our own data and seeing that although we were doing well for molecular testing, reflex testing on cancer specimens, that we're often coming up with quantity insufficient tissue, meaning that the sample is often exhausted before all the testing could be done. And part of the problem was actually single gene panel testing, where we would do, a test for the EGFR, ALK, ROS1, BRAF, and so on. And these single gene tests, although was done, historically, we kind of continue that and knew we needed to improve that. We needed to get a more comprehensive test in place, and we needed to limit that the quantity insufficient results, because these tests are critical, particularly in patients with advanced lung cancer, to have that result before we start first line therapy. So there were four priorities that we came up as part of this project. The first was to how to implement comprehensive reflex testing for appropriate patients. Part of that is streamlining the process for patient scheduling. So often patients are either diagnosed in the community and they get referred to us to be seen, or they're diagnosed within the hospital and they get scheduled for follow-up. Prior to the project, it was not unusual for a patient to be 3 or 4 weeks after a diagnosis is made before we actually see the patient. And if that's the case, we may not even have testing back by then, and it kind of further delays treatment. So one was streamlining the patient scheduling to patients as soon as we know they have a diagnosis of advanced cancer, that they got pushed up into the front of the line and they're seen much quicker. The second was to ensure tissue biopsy sufficiency, and that means collaborating with our interventional radiology colleagues or pulmonologists to make sure we're sampling good samples, and when available, do core biopsies to get enough tissue for that testing. And also to kind of really advocate for molecular testing among all the key stakeholders. That starts from the pathologist, the inpatient, the nurse practitioners, the physicians. And doing these things, really the goal was to get the full results of the comprehensive testing for patients by the time you see them, we have all the answers already and we're ready to go. That would improve, expedite patient care and get them to treatment sooner than later. So, after the project, we did see improvements in the rates, and that was, kind of, we felt that, but when we looked at the data, we did see an improvement in the rates of that happening. But with this project, we did also run into some challenges as well. And one of the major challenges that we had with this project was as we were going into the project, we were actually in the middle of an EMR switchover. And if anyone's ever been through an EMR switchover, it's a huge process. And the data, when it switches over, it's always not exactly where it should be. And what problems we had was that many of these results were scanned as PDFs into the old EMR system. And then switching over, sometimes those PDFs were very hard to find, or sometimes not able to be found at all. And so it made it difficult to kind of look at the data to be confident with the data. So one thing we had to actually do is go back to the source data, to the lab portals themselves, where the NGS test is done, to kind of get it from the source. So that was a bit, we didn't expect we needed to do that, but things happen, and that's what we had to do. The second challenge was actually some difficulty with reflex testing for our Medicare patients. So Medicare patients have something called the 14-day rule in the US, where if they're in the hospital and if you do testing that's within that time frame, that's all bundled within that cost of that hospitalization. And so sometimes these NGS tests can be expensive, and there's some resistance to doing this within that time frame. So we had to coordinate it in such a way that we could get these tests done and not delay treatments. And so we worked with administration to help expedite that. And in some cases, when that wasn't possible, we got the patient in sooner for a liquid biopsy to try to get those results back quickly. There's actually some staff resistance as well, because physicians are used to what they're used to, and they're used to getting their panel tests back quickly, even though sometimes with QNS. And many felt like, well, the NGS test will take longer. Will that delay the treatments? And so there was some resistance, but we worked through that with our staff And once they saw the workflow was working well, we had a lot more, staff say, well, that this process does seem to be better. So those are, some of our challenges and how we overcame that. Overall, I think the big take home for us as an institution was that we got everyone to communicate, and pathologists, the radiologists, the biopsy teams, the oncologists, and everybody was kind of coordinating in a way to kind of expedite the care to have all the results that we need to start patients on treatments in a timely fashion. We learned that it's much easier to order the test through the EMR rather than through the lab portals and paper testing, which we were doing. So one of the learnings from this project was actually we started integrating the genomics testing within the Epic's genomics module. And so we have just a one click, you order it, and the results come back within our in-basket. And so that's really improved the uptake, and physicians feel it's easy to order it that way, and the pathologists feel it's easy to look at it that way. We have the results come back. We don't have to, try to look for it in the fax machine and scan it in. So that whole process really has improved that. And we know if we were to do a project in the future, a similar project, we have that discrete data field. It's like, just query the data and you have your data. And so it's really going to make a difference for future QI projects that we'll do.
Yeah, I think we did a lot of things like Dr. Vu had. I actually had the ability, was first a participant and then became the leader when the leader had left to go to a different institution, actually to Baptist. But I kind of can see both sides as a participant in the intervention and also as somebody that's trying to drive the intervention. I think a little history about Banner is that about probably 4 years ago, we had a director of our cancer center that really believed in multi-D experience, and we really organized to systemize the care of our cancer patients. So most of our patients came through an intake APP, and then from there got set standardized workup that all the physicians agreed on, and then from there went to a multi-D experience where they saw the med-onc, rad-onc, and surgeon at the same time. And at that start of that, we understand the importance of molecular testing. And I think for us, we order molecular testing earlier. Our three main objectives were very similar to Dr. Vu's. The first one was adequate tissue sampling. We originally were doing a lot of CT-guided biopsies for our lung cancer population, and we moved to more of a navigational bronchoscopy biopsy where they would get more tissue. But in that move, also the CT people also, in my experience, also were educated on the importance of tissue for molecular testing and now have embraced that. So I think our tissue yield showed improvement through the experience. So that was important. Our second was kind of how to get the documentation in the chart. Like Dr. Vu said, it was often scanned in. It was not part of the EMR unless you scan it in. It was in different locations and outside records. So it was very hard for physicians to kind of found it, Um, and so that was kind of what the thought was. The second, in terms of the EHR, we were able to make some improvements working with pathology to streamline the ordering and then also get it into the EMR to make it easier to use. I think eventually we're going to move to a system where there's probably somebody that needs to interpret the outside and put it in a set form where it's easy and standardized where everybody can look, because as you know, this testing can be multiple pages and multiple pages of information that's not super useful. So I think how to make it more efficient and streamlined is one of our goals. And then the third main issue for us, which has always been something for us, is decreased time from diagnosis to treatment. And we've always wanted to try to get the diagnosis treatment as fast as possible. And molecular testing, like Dr. Vu had mentioned, can delay or give a sense of delay of care, but is so important for care. So we were able to kind of stress the importance of getting it right off the bat. And we actually reduced 12 days from our time from diagnosis to treatment, which I think is substantial for molecular testing. 12 days is almost a week and 2 weeks, and that time is very stressful for the patients. We're not able to provide care to the same level. So I thought that was a great improvement. I think the improvement really came from awareness. Even though it's part of our protocol, there's so many people involved, from intake APPs to coordinators, nurse coordinators, the MAs on why these tests are important. I think by getting everybody involved and what the reasoning behind the test was very important. But our main barrier was, I think, just kind of physician engagement after the incentives. And it really taught us that incentives of the institution have to line up with the behavior that we want to promote in our physicians and our people. But overall, I thought it was a great first step in terms of letting people know about the experience, understanding the importance, and it did lead to a positive outcomes. And we were already 75%, I think, doing molecular testing on patients, but we got up to the 85% range, which is not 100%, but I think we're making small increments, and those increments are important. But it's not just the physicians at the top that need to know about it; it's everybody that participates in it. I would say was our take-home message.
I think one of the gaps is the landscape is changing so fast in molecular testing. You know, new drugs are approved all the time and new mutations are found. I think in the community, it's hard to keep up with everything. You know, it's hard to know all of these different changes. So I think one gap is a knowledge gap. And I think having, you know, partners like MD Anderson Houston and collaborative tumor boards and, you know, the integration visits that we do can fill some of those gaps for partner sites. But I'm thinking more about these like smaller community programs where they may have these gaps. And so I think, you know, an educational program or something like that to kind of review the molecular tests, the changes that's happened within the last 6 months, a year. I think that could help.
And so these were some questions from the participants who were planning to attend today. So I don't know if these were from any of the ones who are on the call. And the question was about the targeted therapies for thyroid and lung cancer, their benefits, but also about the safety and efficacy of the biologics, and including the adverse effects of these treatments. This figure really just it's a snapshot of most of the approvals in thyroid cancer. Now there are several small molecules. There are tyrosine kinase inhibitors that they are not approved for a specific alteration, but here they are just showing which are the main targets of that. So for example, the lenvatinib that is targeting VEGFR, MET, PDGFR, FGFR, RET, and all these together as it's a multi-kinase inhibitor. However, we have some very specific drugs like for RET mutations, that especially for medullary thyroid cancer, so like selpercatinib, that these are very specific drugs. So, and these really revolutionized how we treat medullary thyroid cancer. And it really highlights the importance of getting molecular testing for patients with thyroid cancer. The same, there is an approval for patients with thyroid cancer who have BRAF V600E mutation. And actually that it is a tumor agnostic approval. That means that dabrafenib trametinib is FDA approved for any tumor type that has a BRAF V600E mutation. So it really highlights, we just focus on thyroid cancer and lung cancer, but beyond that, any tumor type, any patient with a solid tumor should have molecular testing. And the same you can see on the figure for NTRK, for fusions, there are FDA approvals, and this can be found in up to 1% of cancers. And even if it's rare, there are some very effective drugs for that. And just to remember that for the webinars, we reused the NCCN guidelines, and there are some links to check those out. These are updated, and they are used as guidelines for treatment of many tumor types, including thyroid cancer and lung cancer. This is just a snapshot for non-small cell lung cancer. Here are some of the alterations. Now, beyond this, there are others like rat and others that we are testing. But for EGFR, now we have several drugs for ALK, for ROS, for BRAF. So initially, we were testing each one of these separately. However, more and more, it is important to move from a single gene testing or Sanger to a large NGS panel. And as Dr. Wu mentioned, our landscape is constantly enlarging, right? We have KRAS now. We have, I hope, TP53 in the future or other markers that will be targetable. And so it is important to not just have this testing done, but to be able to have databases to capture these patients so we can learn from these in the future, be able to go back to these testings and look who are the patients who have these alterations, right? And so as Virginia, if you're building for, even if it's just for children, but for your institution, if you're building, it will be important to capture the results, create some databases that after that you can use in the future to build on that research. For lung cancer, well, we have the immune checkpoint inhibitors that really change how we treat patients, that improve survival. They have some specific immune related toxicities that we are calling them IRAEs. Some of them are like colitis, pneumonitis, thyroiditis that mimic some of the autoimmune diseases. We have all the targeted therapies, EGFR, ALK, ROS, and so on, inhibitors that they are very effective in specific mutations. Some of these can cause rash, diarrhea. Now, for some, we could go into more specific side effects, but often these are oral drugs that are well tolerated. There is a new type of treatment that it's which are antibody drug conjugates. These are antibodies that take chemotherapy directly to the cancer cell. One example is trastuzumab deruxtecan, which is targeting HER2 mutations in lung cancer. One of the possible side effects is interstitial lung disease. However, we are able to detect and manage, and this has shown significant efficacy in patients who have HER2 mutations. For thyroid cancer, as I mentioned, that we have these multikinase inhibitors. These, because they also target the VEGF pathway, can have some effects that we call anti-angiogenic. We can see hypertension or bleeding, but also some of them can cause increase in the liver enzymes. And for the RET-specific inhibitors, these are very well tolerated and with more rare liver toxicity. So for the other therapies like the dabrafenib, trametinib, patients have the rash, diarrhea, but often these are manageable side effects. For lung cancer, now we have combination therapies, especially in between chemotherapy and immunotherapy, that has an increased efficacy, but also leads to some overlapping toxicities. And for all this, really, it's key is early detection and specific multidisciplinary management.